everyone. Welcome to this presentation on how to support people with knee osteoarthritis to engage in exercise and physical activity. I'm presenting this to you from the lands of the Wurundjeri people, and I'd like to pay my respect to the elders past, present and emerging. My name's Associate Professor Christian Barton. Today we're going to talk about a few things. We're going to talk about how to provide high quality patient-centred education. We're going to talk about how to address patient education priorities. We're also going to talk about the context of education to improve engagement in first-line care, including exercise therapy and physical activity. We'll talk a little bit about some outcomes from the Good Life with Osteoarthritis program from Denmark, also known as GLAD, that we've found in Australia. And I'm going to present to you a freely available patient education and self-management toolkit called My Knee, which is development has been led by Dr. Anthony Goff. So firstly, what do guidelines tell us to provide people with knee osteoarthritis? It can be clearly delineated into three lines of care. First line being education, exercise, and weight management for those who need it. This should be provided to all people with osteoarthritis. There's a range of second line therapies we can provide, pharmaceuticals, injections, a whole range of different passive treatments and modalities, gait aids. And then the third line of treatment should be considered only for very few people. And this involves typically surgery and probably really only total knee joint replacement surgery in most of the population. So if we consider the evidence behind exercise, this is a great figure produced by 𝐒𝐂𝐁𝐄, which we teach in our GLAD Australia course provided by the Danish team. And what you'll see is a forest plot looking at the effect sizes of exercise compared to a control intervention. And you'll see to the right-hand side, which would favour an exercise therapy intervention, that the forest plot sits along that side, and you'll notice that the dots always go down that right-hand side with the confidence intervals, so the lines either side, becoming smaller and smaller over time. So what this means is the accumulative evidence is built up over time that we can be more and more confident that exercise therapy is supported by evidence. If we actually look at systematic reviews of this literature, even from a number of years ago, we can conclude that as of 2002, we probably had sufficient evidence that we should be providing exercise therapy to all people with osteoarthritis, and further trials were not really needed. So if we look at this graph, we really haven't needed any studies since this. In fact, this graph hasn't been updated for a number of years. There's been a lot more since. If we have a look a little further at exercise therapy, what we also know is that it is cost effective compared to usual care. So it's certainly something that should be implemented. The question often gets asked is, well, what type of exercise therapy? The good news is that many types of exercise therapy can be helpful. Aerobic, resistance training, functional exercise, a whole range of different approaches can be effective for people with osteoarthritis. The key is getting them to engage in some form of exercise therapy so that they can move forward and actively manage the condition. So if we look to the Australian guidelines, which is where I both work in research and in practice, it's very clear that all people should be offered exercise support and strongly recommended. The important part of this is regardless of pain, function and disease severity, whether that be pain intensity or structural changes that might be a result of osteoarthritis. So this is something we should be providing to everyone with knee osteoarthritis. Interestingly, in Australia, just 1 in 20 are referred for physiotherapy support or any form of exercise support from a GP. So that's a really low rate. If we compare that to surgical referral, it's more like 15%, and opioids sit around 15 to 25%, just for a little bit of context. So one of the ways that I like to consider the patient in front of me when I'm treating people in the clinic, but also when I'm thinking about my research, is this concept of patient-centred care and thinking about the socioecological framework. So this places the person in the middle, their behaviours and their treatment choices. They'll be influenced by a whole range of intrapersonal factors, which we can influence as clinicians. And they're also influenced by a whole range of interpersonal factors. So we're not just talking about our role as healthcare professionals, but a whole range of social influences, friends, family, colleagues, etc. And then also media portrayal of the condition. We also know that environment plays a big role, so natural environment and built environment and infrastructure, but also the healthcare environment of what services might be available. So when we're thinking about why don't people engage in appropriate exercise therapy and engage in active management and physical activity, this is a nice way to frame our considerations. So what do people with knee osteoarthritis do? We know most don't meet physical activity guidelines. In fact, most people in general don't, but people with osteoarthritis in particular are less likely to meet physical activity guidelines compared to the general population. In Australia and all around the world, most people also do not engage with appropriate first-line care, so that being education, exercise and weight management where indicated. There's a whole range of factors that might link to this in terms of intrapersonal factors. So beliefs about osteoarthritis, we see this pervasive impairment discourse where people believe the condition is wear and tear disease. They've got fear of pain and damage with exercise. They believe exercise is dangerous. They underestimate the benefits of exercise, and many people also believe that surgery is inevitable. They often have limited knowledge about the condition, and in particular limited knowledge about treatment options and the benefits and safety of various things. So they may overestimate the benefits of things like surgery and injections and underestimate the potential harms, and the opposite for exercise and physical activity. And they often have limited self-efficacy, motivation, and that capacity to self-manage, particularly in relation to exercise and physical activity. So quality education to address many of these factors is really, really important for us to consider as health professionals. So what does the education research literature look like? So Anthony Goff, who is a PhD student I had the pleasure of working with for a few years, who has now graduated earlier this year in 2022, produced a really great systematic review in Journal of Physio. And in short, what it shows us is that education does have supporting evidence, but as a standalone treatment, it's not all that effective. If we combine education and exercise therapy compared to education alone, it is more effective by adding the education, and equally if we add exercise therapy to education, that is also more effective. So the combination of education and exercise therapy is more effective in the short and medium term compared to both of those individual treatments alone. Now, one of the problems we have when we look at the literature is that there's really poor reporting of intervention trials, so broad and inconsistent provision of education. A lot of education interventions are not informed by theory. Very few are co-design, in fact just 1 in 10, and often education is used as a control. So there's not a lot of skill development and really learning outcomes, which would be a key part of an education intervention, are not usually well defined. So education in terms of evidence of efficacy is perhaps even underestimated in the literature. So we started to consult with both people with knee-OA and also physical therapists or physiotherapists about their priorities for patient education, and we use what's called a concept mapping design. So we recruited people from public and private physio clinics here in Australia, and we got them to brainstorm and we got them to sort and rate various education priorities. And we also recruited physical therapists who were treating people with knee osteoarthritis, and we got them to do the same thing. From our patient population, we identified 76 priorities. From our physiotherapy population, we identified 56 priorities. And if we talk about them briefly, firstly, people with knee OA, they really wanted to understand the relationship of education and exercise with surgery. So could they use this to avoid surgery? Would surgery be inevitable, etc.? They also wanted to know more details about surgery, which I think is a really important context for us to consider. From an exercise perspective, this was also a key priority, and they wanted to know how to exercise and why to exercise and have access to exercise well beyond a physio clinic, which I think is really, really important. There's a whole range of other education priorities which we must consider, things like understanding medical management and dietary management, understanding supplements, and understanding the condition more broadly. If we look at physical therapists' priorities, logically we would rate exercise therapy as being a key thing, but also addressing radiology misconception, which is going to be really important. So getting away from that wear and tear degeneration to try and get people to think about engaging in first-line care, getting people to understand pain and disability. But again, a whole range of different factors were considered as part of a key education intervention from physical therapists to patients with knee osteoarthritis. So we've had a look at many different ways to address the barriers to engaging in first-line care here in Australia. One of the programs that we embraced back in 2016, 2017 and really scaled it up from 2018 on is a program called the Good Life with Osteoarthritis from Denmark program, so GLAD. And what was appealing to us with this program is that it has really 3 key components. The first is that we adequately train physios to deliver education and exercise based on guidelines. We know based on much of our work that we're not always as well trained as we could be to do that, particularly in patients who are maybe unmotivated or have lower exercise literacy. Those physios then go to their clinic and they deliver the program as intended. Although it's standardized, it's able to be individualized to each person, and it's also considered a minimal intervention. So what that means is if there's other interventions that might benefit the person, taping, referral to other health professionals, they're strongly encouraged to be part of the program. And the third part, which is really, really key, is there's a patient registry to collect outcomes. And so we know from that registry what the effect of the program is on things like pain, function, quality of life, thinking about surgery, surgery intentions, medication consumption, etc. So one of the things that we've worked really hard in developing education for people with knee osteoarthritis and hip, for that matter, for the GLAD program, is really trying to use GLAD as a vehicle to change the message. So getting people to think that pain is a modifiable factor. It's influenced by many biopsychosocial factors. And we really want to get away from that bone-on-bone wear and tear. So busting all the myths that are often held as part of knee osteoarthritis and that impairment discourse. We want to then change the treatment focus so we can get people to engage in first-line care, of which exercise therapy is one part, and I'll get to that more in a second. Ultimately, we're trying to put the person in charge of their own condition, give them a really positive mindset. And so the program with GLAD, and you can look at some of the exercises online in your own time if you want to at nemex.socioecological.org. But essentially there's 12 60-minute group exercise therapy sessions, and this involves a whole range of tasks that target knee confidence, target some resistance training, working towards strength, and also target some neuromuscular control. And so the program essentially will build someone's self-efficacy and confidence to engage in exercise. It goes for 6 weeks, so it's a really good starting point. And we know that the minimum exercise dose for people with osteoarthritis that's likely to lead to benefit is around that 6 weeks, 2 sessions a week. Anything less than that, and you may not do well in terms of an exercise outcome, and you might go on to say that you've failed with exercise, which is not what we want to see. 12 weeks is much better than 6 weeks from the evidence, so people are encouraged to continue the process, and the exercise program is really well set up that people can continue to do it at home, which is a really important component of the program. And as I said, it's a minimal intervention, so exercise can be added to this and exercises can be modified as needed for each individual patient. So a bit of context, Eva Roos and Søren Skue, professors at the University of Southern Denmark, were the founders of the program in Denmark back in 2012, 2013, and they supported myself, Joanne Kemp and Kay Crosley to really set the program up. And we weren't sure what we're getting ourselves in for. Things really snowballed very quickly for us in a very good way. We've recruited various research assistants, Matt Francis and Karen Dungiles, and we now have a great postdoc team, including Alison Ezett, Danilo de Oliveira Silva, Marcelo Pazinato, and Josh Heary, who also support the program, along with a whole range of other research assistants and clinical tutors. So you'll see a few faces, clinical tutors there. We now have more than 2,500 clinicians, and the program's been implemented across 600 sites in Australia, in all states and territories, in both public and private settings. So it really has exploded. Even through the pandemic, we continued to roll the program out, and the program continued to expand. From a knee osteoarthritis perspective, I encourage you to read this open access program evaluation paper, which we published a couple of years ago now, which looked at the first couple of thousand of knee osteoarthritis patients and also physiotherapy training outcomes. It certainly improved confidence of physios to manage the condition. But what we can see by providing this standard of care of 2 really good quality education sessions and 12 really good quality exercise therapy sessions, we see real world improvements that match what we see in clinical trials, and that's for pain and quality of life. In fact, 3 in 4 people completing the program report improvements at 12 months follow-up that are considered clinically meaningful. And a really important context is that around about 20% of people are desiring surgery prior to starting the program. 3 in 4 of these people no longer desire surgery and have not had surgery when we follow them up at 12 months. So from a health system perspective, we think the program has really, really high value, and we're certainly starting to see a lot more interest from private health insurers and other public health funders here in Australia. So one of the other considerations is programs like GLAD are not always easy to access because of cost, and that's a barrier because of our health system, but also getting to the program, and some people might like to just explore things online. So one of the things we've all worked with physios in other contexts as well. So with Anthony's work for his PhD, we looked at what's out there at the moment for people to engage with and what's on Dr. Google. Essentially, there's no co-design resources that we identified in commonly accessed websites. Very few provide details about pain, and there's lots of inaccurate information. So some brief context, there is a bit of information out there in some sites about exercise and physical activity and self-management, but there's also a bit of information that lacks clarity, and then some information that really is inaccurate. But perhaps the biggest problem is the, lack of quality information about pathophysiology and inaccurate information, and same about surgery and adjuncts, which may turn people away from engaging in first-line care appropriately. So we went on to develop an education and self-management toolkit called 𝐒𝐂𝐂𝐂𝐿, and I'll share the process here. This was informed initially by some of the work I've talked about already, systematic reviews, looking at online content, and also patient education priority research. We put all of that information together, and then we prototyped a website platform, and then we went through the process of co-designing and developing it further with people with a lived experience of knee osteoarthritis and also with physiotherapists and other health professionals. It was informed by different theories. I won't go through these in huge detail, but in short, we wanted to really support the adult learner and align with patient-centered care. We wanted to look at motivational interviewing principles and looking at self-determination theory, trying to optimize someone's self-efficacy and thinking about how they might be able to do that, and social persuasion, interpretation of symptoms, and lots of modeling, so having lived experience videos, etc. So these were the principles we used. So our prototype, we really had a big focus on knowledge formation inspired by the concept mapping findings I talked about before. We really wanted people to have a good understanding of what first-line treatments were from an exercise therapy perspective, along with a range of other things. And we had things like a frequently asked questions section. We had ways in which people could check their exercises, look at exercise resources and videos, etc. We had videos of exercises that people could access and they could use, and we also had things like diaries that they could fill out and complete. We looked at other ways to facilitate engagement, like a personalised guide maker where people could answer a bunch of questions, and from that it would give them a booklet that they could start to guide their management through. So you can have a bit of a play with that on the website. And then the third aim was we really wanted to be a therapist facilitated resource. So we have sections on the website to guide you as a clinician to be able to use it. And that's a really important context for us, is that it may be used individually and self-directed, but it is probably best used alongside a therapist. So we did workshops and co-design workshops with people with OA and health professionals, and we did 3 of these. They were sent access to the website initially, and then we sat with them and did a 2-hour workshop. And so we did 3 of these, 2 with people with knee OA and 1 with health professionals. This led to additional content, how to navigate our health system here in Australia, and I'm sure that in Canada and other places around the world it'd be great to have some similar resources, and I think it's a really important element to the website. So how do they find exercise services and other services? We had more information sheets about fact and fiction and busting myths. We had more information about things like falls and balance and other challenges people might face when they've got knee osteoarthritis. And we started to incorporate a lot of tests and quizzes, which people with knee OA seem to really like. Alongside that, we had additional exercise videos and things like a work-along video that can go for an hour and people can just pop it on and work through it. We added a lot of other things to improve engagement, more frequently asked question sections, and we also started to put more and more resources around videos, talking to experts, and also, most importantly, the biggest expert of all are those with knee OA, and so we had many videos that we started to create with people giving their lived experience and how they found exercise and physical activity beneficial. So the website is freely available, and I encourage you guys beyond this talk to have a look at it. So visit 𝐒𝐂𝐂𝐿.trekeducation.org. It's been made possible by some great work led by Anthony Goff, who I mentioned before, but alongside his supervisory team and many of us in the GLAD team, Alex Donaldson, who led concept mapping, Mark Merrily, who's done some work with us around digital literacy and looking at online content, and many, many more people who have given up their time as people with lived experience and also experts to both develop resources and review the website as well. So make sure you go and check it out. So in closing, my take homes for you today are: quality patient education is really essential to facilitate engagement in exercise and physical activity for people with knee OA. Education about surgery and exercise alongside addressing misinformation should be a priority of us as healthcare professionals. Programs like GLAD provide a great option to ensure appropriate and effective education and exercise therapy, but we also need other resources such as the 𝐒𝐂𝐂𝐂𝐿 site, which we've been developing, and that's a really great resource that you can use. So please feel free to explore it, play around with it, use it with your patients. If you have feedback to improve it or things to add to it, then please don't hesitate to reach out. My email's there and my Twitter handle's there. Thanks very much for listening, and I look forward to hearing any questions you might have.